ANZONA Webinar. We're looking at a part of our series of Ortho 101, and we will be going over fracture radiology and looking at how we look at plain films. My name's Wendy Duperosa. I'm currently president of ANZONA. We're an association which has local chapters through all of the states, territories of Australia and as well with New Zealand. And we're really pleased to have you along for our webinar. First of all, before we start, just want to say when we're talking about looking at plain films, we need to be aware of our scope of practice as nurses. Certainly, we're not going to be going in depth as far as a radiographer or a radiologist does, as far as interpreting x-rays. However, there really is a scope for nurses and particularly specialist orthopaedic nurses to have a lot of knowledge and skills when they are looking at the plain films so that the patients that we're managing, we can be providing them with the better care. So what I will be doing is covering it in a way that continues to meet our scope of practice as nurses, and particularly encouraging you to pick up the more advanced practice skills of a specialist nurse. First of all, what I want to say is that X-ray may provide visual support for possible diagnosis, but it's not the be-all and end-all in everything that we need to do with decision making. They can reveal specifics on bone deformity, joint congruity, bone density, and also the calcification to be providing us with quite a lot of patient information. We can look at the bone texture, size, shape, localized destruction, sclerosis, and fractures can also be assessed. Today's session, what we will be doing is focusing on looking at fractures. Radiological procedures are very helpful, but it's not the most important step when we're assessing and also planning to manage our patients. Really, it is just a tool to really be backing up what we're thinking about, what we're planning on doing, the history, the clinical examination that we're doing of the patient, and the investigations are really just to confirm what we've found from the history and also the examination. They should be interpreted in the context of the patient's symptoms, job, home, and also their individual circumstances. We can't make decisions just on looking at radiological findings. What we need to do is look at the patient as a whole and come up with a holistic plan for that patient. Things like pain and also the motivation do not show up on an X-ray, and they are going to have a very, very big part of our decision making on the management and also how well that patient is going to go post their fracture. There's a few little rules that I want to share with you when we're looking at plain films. First of all, orthopaedic x-rays should always be taken with at least 2 planes, or what we call the rule of having at least 2 views. Lesions or fractures can be missed if we're only looking from one direction, or another bone is imposed on another and a fracture is behind it. There can be shadowing over the top that we're not seeing. Also, it may not show the displacement because it appears in really good anatomical alignment from the plane that we're looking through on. But then when you turn it around 90 degrees and look laterally through, you can see displacement. And this next slide is just going to give you a little example of why we look at 2 views. Okay, what we're looking at here is a plain film, AP view of the ankle, AP meaning from anterior going through to posterior. And looking at this, we have, now if I got little thing, there we go, little marker on the screen. As we can see, we've got the distal tibia that's on view. We've got medial malleolus coming across here. We can also see the fibula, and that goes into the lateral malleolus as part of that subtalar joint, and the talus here. Looks really, really good from this view, and we can't see any fractures. If we were only to have an AP view of this injury, we would be thinking that this patient's doing really well. Put it through onto a lateral view, We follow down the back of the tibia here, or the posterior part of the tibia, and this is the posterior aspect and the malleolus at the back, and we can see a fracture running straight through that posterior part of it. So what looked really good on AP view, we've turned around, we've had a look at the lateral view, and there's our fracture hiding in there. Okay, so we always look at least 2 views so that we can see for that as well. Okay, another rule is that a good X-ray should show the joint above and also the joint below the injury being examined. This is really, really important, particularly for your patients that have come in and said, look, we've had a twisting or a torsion injury, because what we want to do is we want to have a little look at the proximal end of the bone, the joint above, to make sure and see if that has been affected, and the joint below. Okay, again, when we look at tibia and fibula injuries, from a twisting point of view, and particularly an ankle injury, there may be one side that distally a person has done a fracture, and then because of that twisting force following through, you may actually find another fracture at the opposite proximal end of that as well. So as we say, 2 views we always look at, and we like to look at the joint above and joint below, and particularly if you can get that in the one plane film, depending on the size of the bone, that's a good thing to be having a little look at as well. Okay, when we view the X-ray, when the X-ray film is put up on your computer screen, or if you're doing it the old-fashioned way and having a look at it on a viewing box, what you need to do is imagine yourself standing at the toe end of, or the foot end of the patient's bed, looking at them lying down in the bed on front of you and putting up the side of the X-ray that you'll be looking at. For example, the right-hand side of the patient, when we're standing at the foot of the bed, is actually on our left, and vice versa. So what we do is when we put the X-ray up, we look at it so that it's looking at the way that we would be looking at the patient when we're examining them. And which is the right and left of them should be marked on the X-ray. So on this one here, we can see that it's, even though it's on our right as we're viewing it, that is the left shoulder. If I'm examining that patient, the X-ray is exactly the side that I'm looking at from the same perspective, and that makes it a lot easier to be able to see. Okay, before we even start, we need to check the labelling of the films to ensure that it is, first of all, the correct patient, the correct admission that they've come in for, that you're looking at the correct limb, and also what date the films have been taken. So even for a certain admission, they may be earlier films that have been taken. You need to be checking that you're looking at the right films at the right time before you even start. Describing what you see. It is very, very important that you get into a system of being able to describe the actual X-ray and knowing what you're having a little look at. And this is just one of the systems that I personally use and that I've found handy to do. And quite a bit of it I'll stop as we're going along, because it takes certain knowledge and practice to be doing it. First of all, state that this is an X-ray or this is a plain film of, and you want to describe which bone and which patient. So I would say, look, this is an X-ray of the femur on so-and-so patient. Include what joints are actually visible. So I could say, you know, from the femur, I can see proximal femur down to the knee, and let them know which is being viewed. Check that it is the correct patient again at that stage, and what date the films have been taken. Then you want to describe what view of the films that it is. For example, is it an AP view? Is it a lateral view? So I would say this is an X-ray of, this is a AP view of the femur. There is and then that's when you start your description of the actual fracture. So knowing all of your terminology at this stage is really, really important. So is it a transverse fracture? Is it an oblique fracture, which is on an angle? Is it a fracture that is spiraling through the bone? And then providing more information on what part of the bone that you're seeing it. For example, this is a transverse fracture and it's of the mid-shaft of the tibia. And that's giving quite a bit of information with that along the way. Further information that you can then be looking for and describing is describing whether there's displacement of the fracture fragments. Are they sitting nicely and in really quite good alignment, although you can see a fracture line, or are they really quite badly displaced? And to what degree is that displacement? Is it an incomplete displacement, or is there complete displacement of the fracture fragments from each other? Describe if there's angulation of the fragments and to what anatomical direction or plane the angulation is in. This really comes quite in handy when we're talking about femoral fractures. For example, if there's anterior displacement, and when we talk about the displacement, we're actually talking about the proximal component of the fracture, not the distal. Okay, so is the proximal part of it sitting anteriorly? Is there lateral displacement? Again, this is why you need the two views, because looking at it through from an AP or an anterior to posterior view, you may not see any displacement from that way. Turning it around, having a look at the lateral view, and you will see whether there is anterior or posterior displacement. Is there overlapping of the fracture fragments? And again, that's going to come in with our femoral fractures. We know all of that power of the quadriceps when we have a mid-shaft of femur causes quite a lot of overlapping of the fracture fragments. That's something that you can be having a look at and describing. Does the fracture appear open or closed? Hopefully we've already ascertained that from our clinical examination of the patient. But if you're being asked your opinion or looking at some plain films of a patient that you haven't clinically examined, because maybe someone's asking you advice, have a little look at that, and there may be certainly visible whether the fracture will be open or closed. Some of them, particularly if they're really quite displaced and there's gross displacement of the fracture, you will know straight away that it would have gone through the soft tissues and you're looking at open fracture. Other times what you may see is air on view under the soft tissues. That will probably suggest that it's an open fracture. And then in that case, if you're unsure, it's going back to that clinical examination that's also important. You need to be describing the surrounding soft tissues, because that will give you quite a bit of idea about the velocity of the trauma to the patient. You will see whether there's a lot of edema, as we've already said, whether there's subcutaneous air that's under the soft tissues. Have a look at this stage as well for any abnormalities in the density of the bone and the texture of the bone. And certainly with our older patients, our proximal femur fractures, this is an important part for us to be assessing as to, you know, what are the state and the health of those bones, how much degree of osteoporosis are we looking at. If the fracture is near a joint, what we want to do is describe whether it goes into the joint or the fracture is intra-articular, or whether it's extra-articular. So that's another thing that we can describe. When we're dealing with children or adolescents, it's having a look to see if getting the hints from their epiphyses to estimate the maturity of the bone. And that's something that, again, comes down to scope of practice. I personally don't work a lot with paediatrics, and it wouldn't be something that I would necessarily be able to do just straight off the top of my head. But, you know, looking at the resources around as to a lot of the rules as far as skeletal maturity, and for people that are working in paediatrics, you know, that's an important part of their role to have knowledge of. Okay, some hints from developing your skills. It's not one of these things that you can just listen to a half-an-hour webinar and say, right, I'm going to be good to go now. And we certainly don't expect you to be able to do that. It's something that you need to work on, and it's a area that you need to work on over time, and it's something that takes a lot of practice. And it's having a repetitive system of how to review the X-rays. So if you've got a framework like the framework that I've just described, or you may have come up with a way yourself to be doing that, but it needs to be fairly consistent, that's how you're going to start to develop your skills with it. First of all, be familiar with plain films which show normal anatomy. Okay, we can't look at the areas that are abnormal until we know what normal anatomy is supposed to look like on radiology. Okay, so knowing what they are looking like, and the more familiarity you get with that, the more that you're going to pick up when it is altering from that. Get into, and this is really, really important, and I can't emphasise this next point enough, get into a habit of reviewing the plain films of the patients you're actually caring for whenever possible. Okay, as frequently as you can, and I know that takes a lot of extra time when you're in the clinical areas, but it's something that's the only way that you're really going to fully develop the skills with this. Two patients with the same diagnosis can have a completely different injury, and it can have a lot of impact on the way that you're managing that patient. So if you're getting into that stage, and you know, it is a little bit easier these days that we can bring it up onto a computer screen and have a bit of a look, do take that extra few minutes, bring up their radiology, have a look at their films, and it will really change the way that you manage your patients. You know, it's happened to me before that a patient's come through, they've been handed over to me, and the handover has been very scant on information. For example, this patient has a fractured femur. They've come through. Patient with a mid-shaft femur from a high velocity injury is going to be completely different in your management from a patient that's come through low velocity fragility fracture fall of their proximal femur. Okay, could have been told the same thing, fractured femur. We all know as orthopaedic nurses that that's really quite a different kettle of fish. Okay, so do get into the habit of having a review of your patients that you're looking after. Visualise the injury that you're dealing with, visualise the injury that you're managing. Certainly when you're looking at the pain management, that's going to be giving you a lot of hints along the way if you can actually picture and visualise the injury that's sitting there under the skin for you as well. To have a look at the normal as well as the abnormal, and I know I haven't put a lot of films up today, the best thing that you can do is go to some of the really valuable websites that are around. This is only one of them that I've got up on the screen, which is Wiki Radiography, and work through a lot of the modules that they've got online. For example, Wiki Radiography, they have a whole lot of the plain films that are all nicely labelled, and there was that one that I showed earlier in the presentation of the shoulder that was all beautifully labelled. Familiarise yourself with the normal anatomy and what it should look like, and then start working through a lot of the different fractures that they put up, and work through the modules to develop that as a skill for yourself. In conclusion, X-rays and plain films are a really effective diagnostic modality, but they're there to support our assessment and also the appropriate treatment of orthopaedic patients. Okay, and that's all I really wanted to say on that. So thanks to everybody that has attended. I know that there will be people listening along at a later date, and you can contact us via our ANZONA Facebook page or also our ANZONA website if there's any further information that you would like on this topic. I can't emphasise enough, as orthopaedic specialist nurses, this is something that we really do need to develop. We need to develop very much as well the sort of language that we use to describe injuries and fractures, as far as transverse, oblique, using different terminology as the body planes that we're dealing with, whether things are proximal, whether they're distal, anterior, posterior, medial, lateral. I could keep going on, but all of those, that sort of terminology just should be part of our normal language when we're communicating regarding our orthopaedic patients. And knowing all of those things is going to make it so much easier when you're looking at plain films and trying to describe them to someone else. It is a part of our scope of practice, and it's something that I hope that you will get on board and develop as part of your skills. So thank you very much.
Thanks, Wendy. I think that's I think it's such an important part of orthopaedic nursing practice. And some people may say, well, you know, we're not making diagnosis. Oh, can you hear me? Yep, am I coming through? Yes.
Yeah.
Yep, sorry, I just, for a minute there, I thought, well, my sound wasn't coming through.
No,
Yeah,
no.
so some people may say that, you know, that's not really part of our role as orthopaedic nurses, but having a good understanding of the injury, the fracture type, the location, even the sort of quality of the bone is going to give you some hints about what person's weight bearing status is, what the stability of the fracture is, what the type of fixation that's been put in place, and how stable that is, and you know, how much force can be put through that, even if you've got, you know, orders about weight bearing status and all that sort of thing. It's about making, you know, getting that information and making a decision about what that patient's needs are, along with all your other clinical, physical sort of assessment as well. So that sort of stuff's really important, and using the right terminology so that, you know, it's very descriptive and it demonstrates you've got a good understanding. And like you said, is the best way to learn it is just to look at lots and lots and lots of x-rays. When you're starting off, look at x-rays when you know the diagnosis. Look at x-rays with someone who can tell you what the fracture, where the fracture is, what the injury is. So you make that connection between the diagnosis and what it looks like. And then once you start feeling more comfortable with that, then start looking at x-rays without knowing the diagnosis, and try and make a decision in your head, and then go and check the diagnosis. That's a really good way to go about learning. And over time, that gets better and better.
It is, and certainly having the reported X-rays, you know, and having a read through them and trying to find the things that, you know, the radiologist has described on them. And certainly we're not going to be able to see it from the depth of what they're describing, but certainly a lot of the gross appearance of the radiology we should be able to pick up on. Yeah, and I think that really, really helps with the patient's care, because, you know, quite often, you know, they might have come in for an ankle fracture. Why they're complaining that the area around their knee is sore? Is there something that we need to investigate a little bit further and have a look for them? Again, considering that mechanism of injury, and that's another thing that I can't emphasise enough, is we need to know that mechanism and get a little bit more description of the mechanism, so that we understand a little bit more about the characteristic, you know, the personality of the fracture that we're looking after for that patient. Because, you know, so many of the fractures really do present with quite a different personality, knowing what we're looking at. You know, how many fragments or how many pieces, is it comminuted, you know, and really shattered, you know, because certainly we will understand much more about the patients that we look after if we've got a much better idea, and being able to visualise the injury really does change the way that you manage them, I think. Yeah.
Yeah, no, that's really important, and it'll give you an idea about the severity of the injury and what the potential risk of any problems with neurovascular status, what compartment syndrome. If it's something like a pelvic fracture, you get to have a sense of, you know, what are the risks of significant hemorrhage. All those sorts of things are really, really important as well.
Yeah, because, I mean, again, it wouldn't be unusual for someone to be, you know, us to get a call to say, right, you've got someone with a pelvic fracture coming in. You know, is that someone that's just, you know, got one area of ischium that has been fractured, or is it someone with an open book, you know, really quite severe pelvic fracture? There's just so many ends of the spectrum as far as fracture management goes, with what we need to manage for the patient. You know, some pelvic fractures can come in and we can maybe be, you know, to pain tolerant, starting to mobilise them, because it is just a very, very isolated fracture area, compared to someone that's got a very unstable fracture that, you know, we're going to need to know whether we need to look after them hemodynamically to make sure that they're stable, and keeping a closer eye on their management. So, you know, I think it's really, really important. And as you say, neurovascular status, if we see a fracture that's twisting around the head of the fibula, and we can visualise that within our head, we can think straight away, okay, let's think about common peroneal nerve. I'm going to need to keep a really, really close eye on that patient's neurovascular status. 4 hourly may not be enough to be assessing that patient. I'm going to need to be, assessing them a lot more frequently. So it does alter your nursing management if you can do that.
Yeah, that's really important, I think. So.
Yeah.
Excellent. And maybe we should have a presentation on pelvic injuries. I don't think we've done one yet, have we?
No,
Useful,
that
actually.
would be a good one, because that's certainly something, people are always saying, should we, shouldn't we be rolling? There's usually quite a lot of questions on all of that as well.
That's good. All right, excellent. Well, thanks for that. I'll stop recording.
Okay, thank you.